Hey everybody, good morning. Good morning. How are you all today? Awesome. That's good to know. For those that don't know, there might be a face or two in the room that don't know who I am. My name is Stuart Schlossman. I too have MS. Thank you. Are you clapping that I have MS? Thank you. I appreciate that. Thank you. Thank you. The Stu part, yeah. Once known as Stu's Views and MS News, we became corporate, several years ago. We're MS Views and News. We're a patient advocacy organization. We're now providing programs in 23 states. And that's part of our growing process, all right, is we're just trying to do more and more. So now, listen everybody again. I'm going to ask you all again, hold back on all the talking at your tables. Wait until we do the Q&A, and then if you really have something to talk about, you could ask a question, all right? So Dr. Williams earned her Bachelor's of Science degree in Neuroscience and Behavioral Biology from Emory University and Doctor of Medicine degree from Morehouse School of Medicine. She completed her residency and MS fellowship training at the Medical College of Georgia at Augusta University. She currently serves as a board member and a member of the Clinical Advisory Committee for the Georgia chapter of the National Multiple Sclerosis Society. She is also clinical advisor for the Multiple Sclerosis Foundation and speaker for the Multiple Sclerosis Association of America, now MS Views and News too, right. She remains actively involved in clinical research, and her research interests include investigating the course of MS in women in ethnic minority populations. Dr. Williams remains dedicated to educating patients, families, and her colleagues about multiple sclerosis. Let's now welcome Dr. Mitzi Williams. That mic.
Perfect. All right. I'm a walker. I'm going to hold it and walk. Good afternoon, everybody. I was about to say good morning, but good afternoon. How's everybody doing today? Good. I am so excited to be here with you all today. I see so many familiar faces, and I see some faces I've not seen before. As Stuart said, I work at the Multiple Sclerosis Center of Atlanta, where we have the privilege of seeing and taking care of somewhere between 4,000 to 5,000 MS patients a year. So I'm going to talk to you a little bit about your healthcare team. And for those of you that have heard me speak before, I generally am an interactive speaker. I know that we have a specified time for questions and answers, but I will try to cover some material, and if you guys have any questions that I can answer quickly, I'll try to do that at the end before we go to our large Q&A session. All right, very good. So let's get started. Teamwork makes the dream work, okay? So we're talking about comprehensive care in multiple sclerosis. And I like to say, kind of like how it takes a village to take care of a child, right? Anybody got kids? I've got two who are with my mother right now. So it takes a village to take care of a child. It takes a village sometimes to take care of people with MS as well, right? And how many people know that you have sometimes many different people that are a part of your village or your healthcare team? Okay, so before we go into that, we'll say, what is MS, right? And many of you who have heard me speak before know that I usually kind of give a little quiz in the beginning and ask what MS is, but I won't do that because you guys are digging into your food, which looks great. So I will just spare you that pop quiz this morning. But MS is an autoimmune disease that affects the central nervous system, which includes the brain, the spinal cord, and the optic nerves. And basically, the immune system attacks the myelin or the coating of the nerves, and that results in the symptoms that we see from MS, whether it be numbness or weakness or some of those other things. But I like this picture because it talks a lot about the other things that go on with MS, right? So MS is not just about a disease and about symptoms, but there are a lot of ways that MS affects a person, affects their family, affects their relationships, affects how they view themselves in the world. And so there's a lot more that goes into MS than just symptoms. All right, and how about symptoms? What are some symptoms of MS? All right, can anybody tell me what this picture is here? What does that represent? Right, so numbness and tingling, burning sensation, right? So paresthesias, what about that one? What is that? Cramps or spasticity, absolutely. I just wanted to make sure you guys are awake. All right, what about this one in the middle? I miss Michael Jackson. Balance, right? Don't we all wish we could balance like that, right? And then how about this one? Absolutely, how everybody's going to feel when they finish eating, so I'm going to talk fast, all right? And then how about this one at the bottom? Exactly, right. So those are just a few of the symptoms with MS, but certainly there are many more than that. Okay, and so how do we manage or how do we deal with MS? So there are a couple of different ways that we manage or treat MS, and I kind of like to think of it like a 4-layer cake because I like cake. And also I'm on a fitness challenge for, where's our fitness guy? I'm on a fitness challenge, so I can't eat cake. So this is as close as I'm gonna get to cake until Thanksgiving. But look at it like a 4-layer cake. So the first layer of the cake is acute therapy for exacerbations, right? So if someone comes in with a new symptom, numbness or tingling or loss of vision, there are medications we give for that acute episode, okay? The second layer is disease-modifying therapy, and those are the medicines that we use or that your doctor prescribes to try to prevent those relapses or acute symptoms, to try to slow progression of disability, and to try to prevent new lesions on MRI, okay? So that's the second layer. The third layer is symptomatic management, and that, going back to those symptoms that we saw on the slide, depends on the symptom. There are some symptoms that we have good treatments for, and there are some symptoms that we really have no treatment for. But talking to your doctor and talking to them will depend on how that's managed. And then lastly, the fourth layer of the cake is rehabilitation if that's needed. And that includes physical, occupational, vocational rehabilitation, and we'll talk in a little bit more detail about those as we go on. All right, so who's on your team, right? So we talked about teamwork making the dream work, and this is the patient who's in the middle, right? So the center, right? And then certainly you've got all these other possible folks here on the outside. We're going to touch on a few of these, but sometimes it takes all of these people depending on what your symptoms are related to your MS. And we'll come back to that. Okay, so what about the neurologist? So what does the neurologist do? So if you have MS, it's good to have a neurologist on your team, okay? The goal of the neurologist is to help manage disease-modifying therapy, okay? So the neurologist basically takes care of the first, second, and some of the third layer of the cake, okay? So remember those 3 layers? The neurologist helps with the top 3. So they help manage disease-modifying therapy, okay? They may review and order MRIs, okay? And that's one way that we look to see how medications are working. They also help with symptom management. Sometimes if the symptoms are kind of out of the scope of practice of the neurologist, they may refer you to someone else, right? Which expands that team. And then also they may help with medical equipment needs. If you need things like a cane or a walker or a wheelchair, they may refer you to the appropriate places for that. So the neurologist is really central to helping manage the MS, but also helping manage the symptoms. Okay, what about a primary care physician? How many people know that even if you have a neurologist, you still need a primary care physician? Raise your hand real high, because I still got people coming in saying, Dr. Williams, my nose is running. Can you give me an antibiotic for a cold? And I'm like, no. Go see your PCP, right? So primary care physicians are very important, right? Even though neurologists will often handle some of your regular medical issues, it's important to have that person. They're kind of like the gatekeeper, right? So they're the person that would probably keep track of all the different referrals, all the different doctors that you're seeing, and kind of know what's going on in all of these different areas. They also can manage your general health concerns if you have other medical conditions like diabetes or high blood pressure or high cholesterol. They would manage those things. If you have acute infections like that sinus infection everybody comes in and wants me to prescribe antibiotics for, that would be the person to go to for that. And then also they will refer you to other physicians if appropriate. Okay. All right, what about mental health providers? Mental health providers are very important to MS. Number one, and I think that someone else is going to talk a little bit more about mood later, maybe Tracy. Mood is important because over 50% of people with MS experience depression at some point during the course of their MS, so it's very common. People also experience anxiety, and people with MS also have other mental health conditions, just like everybody else. So there are a lot of different mental health providers that can take part or be a part of your team. So psychiatrists are medical doctors that can help with prescribing medication. So for instance, if someone comes to see me and maybe we've tried 2 or 3 different antidepressants and none of them are working, then that might be a point where I might refer them to a psychiatrist for management of that problem, because we've tried several different things and they're kind of resistant to that. So I usually say, this is my lane, okay, and I try to stay in my lane. And when something gets out of my lane, then I put you in the person whose lane that is. is, okay? So psychiatrists are specialized doctors that help with that. Psychologists are generally doctors, people with a doctorate degree, so they're not medical doctors, but they have a PhD, and they often help with counseling, okay? So one of the best treatments for depression and anxiety for MS is a combination of medications plus psychological counseling, right? So I usually say there's a part you play and there's a part the medicine plays, right? So the medicine plays a part, but you also play a part, and that part is getting counseling, getting help, kind of dealing with those coping issues. I always also say that there is no happy pill that's legal, right? So antidepressants are not happy pills, right? They basically even you out so that you can get the extra help that you need and be able to function. So psychologists help with that counseling. Licensed counselors also help with counseling, and it just depends on a person's preference and the availability of those specialists in their area, whether they may go to a licensed counselor or to a psychologist. There are also neuropsychologists, which Dr. Gottsol is a neuropsychologist, and so they also can do counseling, but in addition, they may do neuropsychological testing, okay, which is specialized testing to kind of help us understand what parts of your cognition are affected. Many people with MS have cognitive impairment or difficulty with their memory, and so often that testing can help us kind of tease out maybe what part is from the MS, maybe there's some part related to fatigue, maybe there's some part related to depression, and kind of give us a better strategy on how to approach that. So also mental health providers, as I said, deal with symptoms like depression, anxiety, other psychiatric disorders. Depending on who you see, they help with medication management and counseling and neuropsychological testing. All right, who else is on your team? So let's talk a little bit more about therapy, okay? So therapy is very important in the treatment of MS, and most people deal with some type of therapy at some point during the course of their MS. And these are just examples of different types of therapy, and we'll go into a little bit more detail about these. So physical therapy. Physical therapy can help with things like gait and balance. It also can help with muscle weakness and difficulty with coordination. And to me, there are a couple of goals when we send folks to physical therapy. One of them is to try to find a personalized exercise routine for you to do at home, right? So again, the part you play, right? And then the other part is sometimes they will help us with equipment needs, like tell us what's the best device that you need. Do you need a cane? Do you need a 4-prong cane? Do you need a walker? Do you need a scooter? So they can help us with the best type of device that you need to help you stay up and mobile. They also can help with techniques for energy conservation, because if we're not moving appropriately, right, you can expend a lot of extra energy trying to move. So maybe, for instance, for people who have foot drop, right, there are braces you can use for foot drop. If you don't have a brace, you may use a whole lot more energy trying to walk and be more fatigued earlier than if you have that brace. So simple things like that can often significantly improve quality of life. And also fatigue management is important with physical therapy. Occupational therapy helps with your activities of daily living, such as feeding and dressing yourself. I used to have a picture of my son with food all over his face, but I took it out. But if you can imagine, well, I have a daughter now with food all over her face. So, but they help with preparing meals and also help with enhancing independence. Sometimes there are devices that can be obtained, like you can get devices to help you button your shirts and things like that, just to try to maintain independence. Also, speech therapy can help with exercises, communication devices. They can help with voice training, and they can also help if you're having swallowing difficulty. So speech therapy can address both of those things, including difficulty with slurred speech as well as difficulty swallowing. All right, and how about cognitive rehabilitation? These services are often very limited. It's kind of hard to find people who do cognitive rehabilitation, but in some places it is available. And basically, after cognitive testing is done, there are neuropsychologists that can help with rehabilitation, exercises, and things you can do to try to improve the weak areas of your cognition. All right, and then vocational rehab, also important, because oftentimes MS may cause you to not be able to do what you were doing vocationally, right? So you may have worked so for instance, I had a patient who worked as a home mortgage broker, but wound up having a lot of cognitive issues and was no longer able to do that. So vocational rehab often helps identify skills that you can do, to remain employed. Maybe there's something else that you can do. They also do job training and some possible job placement assistance. All right, care partners. So I pause here because even though we're talking about the healthcare team, care partners are an important part of your healthcare team. Why? Because I generally call care partners the truth tellers, right? Many of you may have heard me say this before. So you'll come to an appointment, I'll have a patient come to an appointment with their spouse, and I say, well, how are you doing? And the patient says, I'm doing great. And the spouse is like, no, right? And it's not necessarily that they're telling on you, right? And a care partner can be a spouse, it could be a friend, it can be a relative, a brother, a sister, a cousin, whoever is in your circle, right? And they're often not necessarily telling on you, but they may see things that you don't see. So you may not remember that they had to tell you 10 times the same thing over and over again. Or you may not see those little changes that happen day by day that they notice. And so it's important to have someone else on the outside who's observing things because they may see things you don't see and be able to relay that to your doctor to give us a better idea of how you're doing at home. And also, they often tell us if you're taking your medication or not, right? Yeah, so they do tell on you in that respect. But it's important to know that they are a huge part of the healthcare team because they can help with management at home. They can also help you recall symptoms. And also emotional support is important because MS, does affect you emotionally and you need that support at home. Okay, so what can you do to extend or be a part of your healthcare team or to help, make sure you have the appropriate healthcare team? So things that are important are keeping track of changes and symptoms in between doctor's visits. When people come to see me, if I have some of my patients are here actually, they usually bring me notebooks, right? So they'll bring me a notebook with a list of symptoms. They may have it in their calendar on their phone. They may have it in the notes section on their phone because we can't address symptoms that we don't know about, okay? And it's important to have those symptoms in front of you when you're at the doctor's visit because how many know if you go home and you're like, oh, I forgot to say so-and-so, you don't get quite as good a response as you do when you're there in front of the doctor. So you have to keep track of those symptoms and changes so that we know what's going on. And then if there are symptoms that are getting worse, then we know if we need to extend your village, right? If we need to refer you somewhere, if we need to have you see someone else, a specialist, to talk about those things. It's also important to discuss your concerns and issues with your doctor, okay? People are not shy when they come to see me. People tell me all kinds of stuff. Sometimes I'm like, whoa, But it's important to have a good relationship with whoever you're seeing so you can address those things. Some people have sexual dysfunction, and, we're not shy in my office. But, if we don't know you're having that problem, we can address it, right? So you have to be with someone that you feel comfortable with where you can talk about things that are affecting your quality of life so that they can be addressed, right? It's also important to educate yourself. It's so good to see so many faces at a program like this. You have to educate yourself, not just about new treatments, about what's going on in the field of MS. Stu's News and Views does a great job of this. Matter of fact, I was on the email list for a while. Woo! Kind of keeping people abreast of what's going on in the field of MS. Sometimes people will come in with articles from the website and be like, hey, did you see this, Dr. Williams? So that we can make sure that we're keeping the dialogue open. And if there are other treatments or options available to you, that we can make sure we address those. And also, don't be afraid to ask questions. If you don't understand why you're taking a medication, what's going on with your MRI, what is going on with the disease course, or why we make the decisions we make, or why we're doing this, make sure that you ask questions, okay? Now, I can't necessarily give you a medical degree in the course of a visit, right? But, make sure that you understand to the best of your ability so that you know why you're doing what you're doing and why your doctor has the opinion that they have. And then finally, involve care partners. That is really, really important, okay, to involve whoever is a part of your village in what's going on so that we can know if there are changes, so that also they can kind of keep abreast of symptoms and how you're doing and help you at home, to take your medications or do whatever treatments or keep whatever follow-ups are necessary. So I think this is my second to last slide. And I really like this quote. It says, when I is replaced by we, even illness becomes wellness. Okay? And that's very important because really it is a team effort. And anyone, if you have MS, know that you are not alone. You have lots of people around you willing to support you. But if we don't know that you need the help, we can't help you. All right, very good. And this is my last slide. It says, all I need is peace, love, and a frickin' cure for multiple sclerosis. Thank you very much for your time and attention.
Awesome, awesome. This is why when I saw those results on what you were doing with the data questions that we were asking, when it came up about how well you guys are doing in Atlanta, I could see why between Dr. Williams and the other doctors that I do know in the area, we need more of this around the country. We really do. Thank you. Dr. Williams is going to stick around because we are doing Q&A after our third speaker, okay? So we look forward to those questions. Write down your questions, everybody. If you have questions, we don't want you to forget. I don't want your memory to be like mine, so, just write them down. All right, next we're going to ask Dr. Tracy, we're going to ask not doctor, not yet anyway. All right, Tracy Walker is up next. She's a nurse practitioner at the Shepherd Center. Tracy Walker also has the MS she's also the MS outcome specialist at the MS Institute, and she has been with the Shepherd Center since 1994. Specializes in treating multiple sclerosis patients. She's a certified nurse practitioner, receiving her Master's of Science in Nursing at Georgia State University. Tracy also earned a specialty certification as a wound ostomy continence nurse at Emory University. Tracy is actively involved in the MS community and frequently speaks on MS issues. She lives here in Atlanta with her son Macon, who is 10, and her mutts, Rugby and Jujubee. Come on up, Tracy. Thank you. This is yours. Thank you much. Oh, you got to go.
All right, great. Hey, everybody. It's good to see y'all. I see some faces I haven't seen in a while, so it's good to see you. Thanks for coming. So today I get to kind of pull things together. And I loved the title that Stu gave me of putting the pieces together because life is like a puzzle, right? I don't know if you guys are like us, but our family at holidays, we love to put puzzles together. And so we'll dump the box out around the table, and actually it's the only thing that will get the teenagers off their phones because it brings out that competitive spirit, right? But now there are a couple of secrets to putting puzzles together. Number one, don't get those puzzles that are all the same color and they're that beautiful sunset scene because you can't tell what pieces go where and you'll just get aggravated, okay? So you got to get little details so that you know at least the area of which that piece goes to, right? And then you got to sort the pieces out. You got to find the ones with the straight edge, put those in a pile, and then find the corners. We have a competition. Whoever finds the corners gets extra points, right? So, so life is the same way sometimes. You got to look at all the different pieces and try putting them together, and sometimes they don't necessarily fit. Maybe you're trying to put the wrong piece in the wrong place. So kind of a little life lesson there. So with MS, you're probably wondering, and you probably know, what a lot of those pieces in between you and MS are, right? But the important thing is those are just pieces of the puzzle. MS is not the whole puzzle, and there are a lot of other things in your life besides that. So, but how do you fit that in? Having MS has some very unique challenges. Many chronic illnesses, they kind of, the doctor can tell you how things are going to go over the next 5 years, over the next 10 years, They also kind of know that, the handful of symptoms you may have with that chronic illness, like diabetes or hypertension, right? With MS, it's a lot more unknown. So it offers some unique challenges in that respect. So let's talk first about managing MS. What are some key things to help manage MS? So first of all, the long term, MS has both acute, sudden things that come up and also long-term chronic things that come up, right? And that's one of the challenges, because next month you may be having an acute change that needs to be addressed. So be sure that you are aware of that. And then educating yourself, your family, your care partner, right? Knowing what you need to do if one of those things crops up. You know, who to call, where to go, what to do. Then MS has so many different symptoms that you really have to educate yourself about what are the options for managing that. And know that, hey, it's okay to go to my physician and say, is this MS or is this not MS? And be prepared for the provider to say, well, I'm not sure. We got to do some figuring out, right? Because sometimes it can be something else. So just sustaining health and wellness is a challenge for all of us. But when you have a chronic illness, it kind of ramps it up another notch in the terms of complexity. So the NIH came up with these slides on what, how do people be successful at managing a chronic illness. And basically, they say you have to have an activated, informed patient, then a prepared practice team, and you have to have productive interactions between those two. So I know Dr. Williams was talking a lot about that and who the members of that team may be, what resources you have, and how to have a more productive interaction with your team. So what characteristics does an educated, activated patient have? Well, they have to have the motivation and the information and the skills to be confident in managing their disease. And it's an ongoing challenge for all of us, but you need that confidence and that education to be able to make the right decision and feel confident in that, right? So what characterizes a prepared practice team? Well, they have to have the information and the resources available to them when they meet with you, right? They need to know what those resources are. And then have the resources they need to deliver quality care. And that may be other team members. It may be time. Time can be one of our greatest challenges now. So, but the team needs to be prepared and knowledgeable too. So, MS today, when I started working in MS, and this dates me, but there were very few choices. And I know many of you were around in those days and know that, you had A, B, C, or D, and that was kind of it, right? So that was stressful, because what do you do if A, B, C, or D, none of them worked, right? What do you have next? Well, now we have a lot more treatments available for MS, and we've learned a lot about how we can affect the disease process. But that comes with its own stress too, because when you have a lot of choices and you're not sure, you're hearing stuff over here and over here and over here, and you're not sure what choice is the best for you and who you should, listen to in regards to making those choices. But it makes the education piece and the active seeking of that education even more important. Okay, I think, we talk a lot about visible symptoms versus invisible symptoms of MS. And, each of those come with their own challenges. But with visible symptoms of MS, it's a challenge because they are visible. And people have sometimes embarrassment or challenges in overcoming those and getting used to those. But then the invisible symptoms of MS also have their challenges, because there's a plus and a minus in having those invisible symptoms. Because if I had a dime for every time somebody said, "Oh my gosh, somebody just told me today, but you look so good," I would love for somebody to say that to me, but I get it, because it's like it's discounting what you're experiencing that they can't see. And so it is. And sometimes with invisible symptoms, you tend to doubt yourself, right? Like, well, am I really experiencing this, or is this in my head? What's going on? So invisible symptoms can really have their own challenges. So visible symptoms can be challenging because you have to alter your environment, and people can see maybe that you're advancing in your mobility issues and may need changes moving forward. So that, comes with its own set of needs and challenges. Invisible symptoms can cause confusion and anger within the family or within the social circles. It also can cause tension within a marriage or between a healthcare provider and a patient. So I think sometimes it's helpful for you family members and care partners in the audience to acknowledge that there are symptoms you can't see, that you can't experience, and that they're real and they're there. And I think sometimes that can help with that, those feelings of confusion within the family and within relationships. So also, invisible symptoms require their own kind of ongoing explanation, right? When something is visible to you, you can see it, right? You don't have to maybe explain as much. Whereas with invisible symptoms, if they change, if they are worse or better or whatever, you have to verbalize that, right? You have to explain that to whomever is in your circle. So I think it's important, those types of issues make education of not just yourself, but of your care partner, of your family, of your children, even more important. Because if you know things, if you've learned things, you can be more active in your care. It helps you know what questions to ask. It helps you make more informed decisions that you're confident about. So it's really important for patient and family education. Also, it helps with coping and adaptation. I really like the term adaptation better than coping, because I know coping is a term that we've used in the medical arena for a while, but really adaptation is the important thing. Can you adapt to the changes in your life? And we all have those changes, but when you have a chronic illness that is frequently changing, it requires a little more adaptation skills. So, but when you are adept at adaptation, you can really, it's empowering to know that you can handle whatever's going to come down your way. So a person that's adaptable, so they did, they've done research and looked at what characteristics people have when they're adaptable or those that have difficulty adapting. And people that focus on being adaptable tend to look at the positive, look at the opportunities. And, I've heard people speak, and in the clinic I've had patients tell me, having this illness has really Not that you would want to choose having the illness, but hey, I can see these opportunities for growth and for character building and for an increased level of intimacy and understanding with the people in my life because of the challenges that arose from this illness. So people with adaptability tend to focus on those positive opportunities. They also tend to accept change as part of life, right? Everybody has changes. Our bodies change, our life changes, people around us change. It is part of life. And so health can be that way as well, or is that way as well. So people that are adaptable also feel more comfortable usually asking for help when they need it. Just some characteristics of adaptable people. Those that have more difficulty with that tend to build resentment or have resentment build up against changes in their life. And we all know that only leads to more health problems down the road. Research has shown that people who have problems with anger and resentment and negative emotions, it tends to lead to really serious health issues as well. Today I will live in the moment, unless the moment is unpleasant, in which case I will eat a cookie. Could be my life motto right there. All right, so one of the pieces of your puzzle is going to be relationships. Now, there are a lot of different relationships in life, and they all come with their own sets of challenges. My best friend gave me a little sign when Macon came along, and he was about 2 years old, and it's a chicken, and it says, raising children is like being pecked to death by a chicken. And only a mother who had lived through those years, would understand that. But just a funny little thing there. But humor is always helpful. So these relationships, we're going to talk mostly about these today, but obviously there are lots of other relationships in regards to work and your spiritual community, extended family and friends, all those types of things as well. So unfortunately, communication is the key, right, to any relationship. Now, sometimes communication means not talking, but listening, right? And sometimes communication means, you know what, I know that we need to talk about that, but I'm not ready yet. Could we put that conversation on hold until I'm really ready to discuss it, So, I tend to be an active communicator. I know that surprises y'all, but so I tend to be an active communicator where I probably like to communicate too much, right? And then you have your, not so active communicators, and sometimes there arises conflict around that, especially around really emotionally laden issues, and your health is one of those. So it can be challenging, but it makes it even more important. Because what happens when we're not communicating is usually people are assuming. They're in their head thinking, well, I know what they're thinking. She hadn't said it, but I know what she's thinking. She's thinking this, she's thinking that, And sometimes your rational self can say, no, now that's probably not true. But a lot of times you can think that way without even realizing it. And then when you go back and you think, did they really tell me that? I'm just assuming that. And then when you talk about it, it's like, oh my goodness, no, that was not what I was thinking. So a lot of times information and accurate thoughts are important. The communication about those is important because you can gradually over time build these big misunderstandings between people if they've avoided certain topics. It's important to listen, and as an active communicator, that's been a challenge for me. And I know that there are times where I'm just busting at the seams to tell somebody this great idea I had, or how they can fix that, or if they'll just listen to me, I can tell them what to do about that. So it's a challenge for me to zip it and listen sometimes. But it's really important to practice that. So common barriers to communication. So we talked about having different, communication and coping styles. Also, just not knowing the information that you need to communicate something, not having the words to communicate it is an issue. And so a lot of times when you go to seminars or meetings or dinners out, sometimes that's when you get those words to communicate something that had been, foggy in your head to that point. So it's really beneficial. So, we often don't make communication a priority, especially now with all our phones and iPads and computers and stuff. It's kind of frightening sometimes. My niece and a friend of hers was in the back seat of my car the other day, and they were so quiet. I thought, are they sleeping? And then one of them snickered. And I'm like, I turned around, they're texting each other so that I won't hear the conversation. I'm like, I want in on the joke too, guys, So, anyway. And then knowing that silence doesn't necessarily mean somebody doesn't care. I think, females tend to sometimes think that the stoic silence from their partner means that they don't care, they don't, aren't, believing them necessarily or something like that, when really a lot of times it's the opposite. They're struggling with how to communicate with you about it as well. So, and tears. I come from a family of criers, okay? If you make me mad, I'm gonna cry. If you make me happy, I'm gonna cry. If you make me sad, obviously I'm gonna cry a lot. So, some people are really uncomfortable with that. And my dad, I remember growing up, when I would get upset and cry, he'd be like, you better stop crying till I'll give you something to cry about. And my dad was a sweetheart, but he was so uncomfortable with that because he's not a crier and not an active communicator, right? So just remember that sometimes tears are good, and we need to practice being okay with those. All right? Things that interfere with family communication. Sometimes as a parent myself, I know it's challenging. How much do you tell your children about what's going on with you or another family member? We tend to want to protect kids from the pain of knowing that somebody has a serious illness or a problem. And, many times there are those conflicting styles of communication that can hinder your family understanding. And then sometimes people are embarrassed to talk about a certain issue or problem, right? My sister, I have an older sister, and she to this day remembers, I was too young, but she remembers one time my mom went into the hospital. And our aunts and our dad said, oh, she just has a bad cold. So she was in the hospital for quite some time, and it wasn't until a couple months later that one of my aunts said offhand, well, yeah, we almost lost her that time. And my sister was like, what? And it turns out she had a pulmonary embolus, and it was a very serious issue at that time. And my sister still remembers the feelings of betrayal and anger that she had no idea what was going on and that it had been misrepresented to her. So it struck me as something to remember when you're dealing with your family, that many times they want to know, and that information can help. So how does information help adults? Well, it helps promote recognition of normal responses in stressful situations. It allows for better communication. You know, you don't have those nebulous things floating out there. And it promotes joint problem solving, active participation in all members of the family. Information helps children because it reassures them that there isn't something you're hiding from them. It gives them the words to talk about what they're feeling and what their fears are about the future. It also helps them prevent that self-blame. Sometimes if they don't understand what's going on, then they tend to blame themselves. And you know, reduces that secrecy in the family. So there's a term that we have now that we use in our family called normalize the conversation. You know, and so sometimes when uncomfortable or serious things come up, we say, okay, let's talk about that, because we need to normalize the conversation, not treat it like it's this big thing that we shouldn't talk about. So, if there are any Auburn fans in the audience, as my grandmother used to say, even a blind squirrel can find a nut every once in a while. So, this is my son making in his Halloween costume this year. He was the Georgia Savage. All right. So families are different. Each family has different dynamics and ways they handle things and ways they communicate, and those can be a good thing. It's not that it's a bad thing. It's knowing that those dynamics are there and how to use them effectively. Preserving the family identity. It's challenging when someone in the family has a chronic illness that maybe has an intense period of time, because the family tends to rally around that person and focus on them and that illness. And that's appropriate. But long term, if it always is all about that, then it really changes the family and can lead to problems, you know, dealing with that. So obviously MS can affect a marriage and the relationship in a marriage. And, you know, there are lots of opportunities to practice communication and learn each other's communication styles, and to normalize the conversation about certain things, because many times roles have to change. The way you've done things has to, you know, change dramatically. Sometimes people have to flip their roles completely. So, but it doesn't have to change your hopes and dreams and moving towards that. So I think one of the other pieces of this puzzle is wellness. And, you know, as a member of the medical community, I will say it's taken us a while to recognize the importance of wellness and treating the whole person. So health and wellness are two totally different things. Now, they interact with one another, they're a part of each other, but they're different. So I love this quote. It says, health is a state of body, wellness is a state of being. And it's an important differentiation to make, because just because someone has a chronic illness like MS, it does not mean that they can't have wellness. They can't pursue wellness and have a successful life. Now, there are a lot of models of wellness out there. And you know, they call them domains of wellness, but I think the important take-home information here is that, you know, you really do need to evaluate all these areas. And when you're thinking of wellness, MS and your physical health are just one part of that. And you have all these other areas like social wellness, like emotional wellness, the intellectual wellness, spiritual wellness. Those kind of things are all areas that need your attention as well. And sometimes they take precedence over your physical health. So it's important to look at the whole person and the whole, all the domains of your life and move towards wellness in those as well. I just love this. I'm launching a new AntiSocial Network. Get out of my Facebook. I recently caved to peer pressure and got back on Facebook because I never knew what was going on with anybody. I got tired of people talking about stuff that I didn't know about. But anyway, that's another conversation. So, outcomes, when you pursue health and wellness with MS, you have a lot of positive benefits, right? You gain a more positive outlook on all the areas of your life and how you can lead a successful and satisfying life even with MS as a part of that. It has been shown to improve mood when people think in the terms of wellness, and it improves adaptability and helps give you the confidence that you can face any problems that come up in your life, that you're able to handle those things or know what resources you have to go to if you need that. And mainly, I think gives people a sense of hope, hope that life is still going to be good, and that there are lots of folks that take care of you. So I think this kind of comes to the end of my presentation, but there are lots of other pieces of that puzzle we didn't talk about. And, I could talk all day long about the different pieces, but I won't do that. But I hope that, today's program has kind of given you some things to think about and look at in terms of the pieces of your puzzle. What pieces might be missing? What pieces maybe are in the wrong place? So I will give the floor away. Thank you very much.
Thank you. Thank you. I'm going to intrude you. Thank you, Tracy. I think every event we've ever done in Atlanta, Tracy has been there. So next, I'm going to introduce Dr. Godsell as soon as my fingers can work and get the right one out here. So Dr. Rob Godsell is coordinator of the neuropsychological services at the MS Center at Shepherd and has been part of the Shepherd Center's team since 1997. He received his doctorate in clinical psychology from Georgia State University, where his specialty interests were clinical neuropsychology and family systems therapy. Following his clinical internship, in which he completed major rotations in forensic psychology and neuropsychology, Dr. Godsell completed a 2-year postdoctoral fellowship in neuropsychology in the behavioral neurology section of the Department of Neurology at Emory University School of Medicine. He continues to pursue his interests in neuropsychology and family systems in working with families and neurologically disordered members. Thank you. That was tough. That was tough. I'm sorry. Some of the things that are given to me to read are real tongue twisters. That one wasn't so bad, but it was tough. Thank you for coming here today.
Okay, I've got to, they say you got to stay right here. I'm used to, as many of you know, because it's really neat being here, by the way, because I'm seeing some folks with whom I have some history, long history, short history, but it's really neat to finally catch up and see where people are right now. So, great. Kate, you two guys right there. Carlos, so great. Great. I'm glad you're here. I was saying, though, that people who have seen me do this before know that I really like to get out into the audience and engage people. That's not going to happen today. But what you may see is me start to drift over and away from the mic. And the gentlemen in the back are going to raise their hands and redirect me. So I'm hoping I can kind of control my ADHD. And by the way, Stuart did a really great job with that introduction. It sounds much more impressive than it is. Sometimes I hear that and it's like, wow, did I do all that? So I was asked to talk about depression and anxiety in MS, and particularly in regards to social isolation. But before we get to social isolation, I thought I would at least speak to some of the points about depression and anxiety as a way of creating some context for understanding. And you don't have to answer this question if you feel uncomfortable doing so. But how many folks here have experienced what they thought were depression? Okay, all right, good. How many folks here have experienced what they thought was anxiety? Interesting, because there's as many, if not more, people who raise their hands about anxiety than depression. Part of the reason why it's interesting is depression is much more known about in MS. We have yet to catch up on anxiety in MS, have yet to catch up to depression. But they're both very prominent. For people with MS, 50% of folks with MS are going to be diagnosed with major depressive disorder at some point in the course of their disease. We're not as clear about that with folks who have anxiety. But what we do know is that neither of them are connected to the MS in ways that we might intuitively know. Okay? And what I mean by that is the research has looked at aspects of MS where people would be vulnerable to depression and or anxiety. And that research has shown there is absolutely no connection with those points or those aspects of people's experience with their MS. Okay, what they are tied to is coping. All right? I'm going to come back to that when I give just a brief summary of treatment. But I want that to, like for that concept, just to stay with you folks about that. Both depression and anxiety manifest in a number of different forms. Okay, for depression, you can have grief, which I think a lot of folks with MS do experience grief. There's also an adjustment disorder with depressed mood, and this is frequently a reaction to being told you have this disease, okay? There's also the major depressive disorders, which kind of go beyond what we would normally expect in terms of a reaction such as an adjustment disorder. With anxiety, it's very similar. There are a number of different kinds of anxiety. One is what's called a generalized anxiety disorder, which is very common. There's also an adjustment reaction. What are more common, more people know about are the phobias. Things like claustrophobia, where you can't tolerate being in tight space. Arachnophobia, which is, anybody know what that is by any chance? Yeah, spiders, you know. I have a friend who can't even look at pictures of spiders, okay? So it can get pretty intense. Then the last one that I thought to mention was agoraphobia. Anybody know what that is? Carlos? Everything? In some ways, yes, but what it actually means, agora is the Greek word for marketplace. And so what this generalizes to is fear of the market, but basically fear of open spaces. Okay? So depression and anxiety share some commonalities, but they also have some differences. With depression, probably more at the core is a fear of failure. Failure of self, failure of accomplishments, failure or fear of failure about future accomplishments. Anxiety is more about trust and control. Okay? The degree to which we can trust ourselves, trust the environment, that's where the agoraphobia comes in, and be able to control the factors that operate in those environments. So when people get claustrophobia, they are so closed in that there's a fear of loss of control. Okay? The reason why I think anxiety is much more prominent in MS than what the research has found so far is because of the effect of the MS in terms of challenging one's sense of control. All right? You have symptoms that occur. You have no control over them, or that's the experience that people frequently have. You have no control over how those symptoms manifest. You have no control over how this disease progresses. So at the basis of this is the core loss of control. Okay? What happens, what these two disorders, emotional conditions also share is some of the origins. These origins have to do with self, world, and future. Okay? But what we tend to do with them is catastrophize. Okay? So people catastrophize about what's going to happen to me. You know, how is this going to play out? Am I going to be able to attend my child's high school, college graduation or wedding? You know, what am I going to do for income? You know, how is this going to be affected? Okay. The two keys here, and Tracy, I thought, did a great job of pointing out that, you know, you need to stay in the moment, unless the moment gets uncomfortable. And frequently what happens when that happens is that people go in two directions. One is they go into the past, okay? And they think about how things were for them before the MS took over, okay? The other direction they go is into the future. And this is in particular where the catastrophizing happens, okay? In both of those existential areas, if you will, you have no control, okay? You go to the past, what's happened has happened. You cannot change that. What happens there with that is then people, it taps into their fear of failure, that they are not going to be able to do anything about this. And so they get depressed. When you go into the future, what you're worried about hasn't happened yet. And when it hasn't happened yet, there's nothing you can do about it. And again, there is a loss of control. And this is where people then begin to get into the catastrophizing. Now, we used to think that when people got depressed or got anxious, that's what affected their thinking. Okay, that people get depressed, therefore they have depressive thoughts. But research over the last 34 years has shown us that the relationship is just the opposite. It's our thinking that takes us down the depressive path. It's our thinking that takes us down the anxious path. Okay, so both of these play out in terms of our social isolation. Okay? The fear of failure for the depressed person is that they don't want to challenge going out, meeting people, being with people. Their fear is that they won't be able to succeed in that environment. Okay? For the anxious person, it's about overstimulation. They get out into the environment, and so many things happen so quickly that folks get overstimulated, and then the autonomic nervous system begins to generate its response. And what happens is, gets kicked in, is the hormones, adrenaline and things. Okay? How are we doing on time? It's okay? There is, and some of you may have heard me talk about this, there's a psychiatrist at Stanford, Robert Sapolsky, and he wrote this book called Why Zebras Don't Get Ulcers. Okay, great title. But what he talks about, and the basic premise for the title, is that zebras, obviously, they live in herds, they live in their communities. The only time they experience stress is when they have to leave the herd to go to the watering hole and drink. Now, the predators, the animals that prey on zebras for their meals, know this. And so they're waiting. The zebras know this, okay? As they get closer to the watering hole, they get more and more stressed out. In particular, then, when they go to drink, because they have to lower their heads, and at that point they have almost no peripheral vision. They cannot see the predators, right? So they drink their water, and if they're lucky, a lion or whatever doesn't come out and get them, or a crocodile lying underneath the surface of the water doesn't come up and get them. And they go and they get back to the herd and they're safe. Now there's two things here that are pertinent for us as human beings, how this applies, is that zebras basically get stressed out 2 times a day. Okay? It lasts for about 20 minutes, because that's how long they have to go to the watering hole that they can leave the safety of the herd and get back. Okay? The other thing is that they leave their community. We know from stress research, and this was back in the 70s, when people became aware of the influence of stress on people's health, that stress could lower the immune system, which made people more vulnerable to all kinds of illnesses. There was research showing that stress could affect people with cancer and some other fatal kinds of disease processes. Okay? What they found, though, was that they found that this occurred predominantly with people who moved away from their communities. The people who stayed in their communities lived normal lives. They had the usual level of illnesses. Okay? So when we start talking about social isolation, it isn't just simply a psychological phenomenon. It's also about health, right? We isolate ourselves, we experience all kinds of things. Loneliness, okay? An absence of stimulation and connection with others are 2 of the main things. Whether you're depressed or you're anxious, these are the consequences of social isolation. In terms of treatment, one of the things that is primary for treatment is to challenge the thinking. Okay? Teach people coping skills, right? I go back to coping skills. Teach them how to challenge their thinking. The catastrophizing thoughts, the negative thoughts, you know, because ironically what happens when people have those thoughts, they become self-fulfilling prophecy, right? So if we challenge the thinking patterns and teach the person to challenge their own thinking patterns, we can effectively reduce their anxiety, we can effectively decrease their depression. So that's basically the treatment. People frequently will ask about, well, what about medication? 30, 40 years of research has shown that by using this process of challenging the thinking, it is actually more successful, more effective than medication. Now, I'm not saying, please do not hear me, Dr. Williams. I'm not saying that medication doesn't have its benefits. It does, okay? And I think you mentioned about it kind of levels folks out. And yes, that's good. Too often, though, people come in and they say, you know, I'm taking the medication, you know, and I'm stable and I'm going to stay with this. The problem is, and where we know that the counseling becomes more effective, 10 minutes? Okay. The counseling becomes more effective is that when you stop each of the treatments, the medication versus the coping skill training, you have much higher level or rate of relapse. What this in effect does, though, is it puts the person then back to where they, in order to kind of gather themselves in, is that social isolation. Okay? Because part of, you know, one of the effects also of that social isolation is you don't come to meetings like this, which it's really important for people, I think, who have MS, is to get that sense of community, to connect with folks. It doesn't have to be that this is the only place where you do that, but this is a really good place to start. It's a good place to learn what you can do and what you cannot do. Because I tell folks who come to see me is that there are two things that if you can work on, I guarantee you, you will be successful. Okay? But basically, one is you have to change the rules by how you've lived. Okay? Now, this is not major, you know, because sometimes folks think, well, you know, if I can't do things the way I've always done them, I'm not going to do them. Okay? That's real dangerous because you deny yourself the benefit of the things that you were doing. So you get people who are used to running 5 miles a day, they say, well, I'm not going to run. Well, you can't do 5 miles a day. What about 1 or 2? And instead of running, walk. Because walking is actually better for you than running. Okay? So it's this mindset of beginning a shift that just because you have MS, it doesn't mean that you give up on life. Give up on doing the things that you love doing. The other thing I talk to people about, or we train them about, and it has to do with the catastrophizing, is you have to figure out what you can control and what you cannot control. And you focus your energy on what you can control. And again, going back to the social isolation, what people fear when they don't isolate themselves, when they go out, is that they're not going to have control. The reason they don't have control, though, the fear is because they haven't figured out what can I control and what can I not control. And if you try to control the things you can't control, you're going to lose. It's that simple. you're going to fail. You're going to be butting your head against the wall. And that's not necessary. Yeah. So, I would invite anybody, to come into, at least in our center, and work on this. It works. This stuff works. We have research that shows it. And it's time to get back out in the world. To go out and engage people, engage in yourself, in what you enjoy doing. Because if you stop doing that, that in and of itself is its own form of isolation. Okay.
But thank you, everybody. Give them a round of applause for speaking today. Thank you. Thank you very much. All right, why don't we start over here then?
My question is for Dr. Mitzi Williams in regards to your conversation about depression and the cognitive rehabilitation and vocational rehabilitation. A person in MS are looking for vocation and looking to improve their cognitive abilities. Do you feel that that causes stress as well in their psyche at times? Because I sometimes feel that I'm so used to having the ability to have been able to work, not being able to, not necessarily find the work, but being able to stay on a job or not really being able to remember a lot of things. I cause that, I think it's called e-stress upon or the distress upon myself, stressing out a lot about those things. Do you find that being significant, and is that the case?
Okay, so your question is, does your cognitive function or does impairment of cognitive function cause increased stress? Well, absolutely. Absolutely. I mean, so cognitive function, I kind of look at it like a cycle, and Dr. Gottsel can probably touch on it even in more detail than me. But it's kind of like several things feed into each other. So we know that MS by itself causes cognitive dysfunction, right? The most common things we see are impaired attention and concentration. People also have easy distractibility, and they have some slow processing. So if you have this much from the MS, right, and then let's say you have fatigue, for whatever reason, because MS causes fatigue and because we give you medications that make you fatigued, okay, then that has the same cognitive effects as the MS, so then it becomes this big of a problem. And then when you add stress, anxiety, depression on top of it, that causes similar cognitive symptoms. So it winds up kind of being a cycle where things are just kind of affecting each other, and then if your cognitive function is not as good as it used to be, then it may make you more depressed because you have cognitive dysfunction. So all of those things play into each other and cause similar symptoms. The reason it's important to recognize it is because, there are treatments for depression, anxiety, stress, counseling, medications if indicated, and also treatments for fatigue. So we try to at least lessen the effects of those things on cognitive function to really see what we're dealing with directly from the MS.
Does anybody else there have anything that they want to add to this? I mean, this is just for everybody, We could start with the primary and then go over.
Covered very well.
Oh, thank you. All right.
I will add a little bit, of course. So I know I heard Dr. Williams talking about cognitive therapy. And we are fortunate at Shepherd to have a wonderful speech therapist who does cognitive therapy. Her name is Bonnie, and I know that Dr. Williams and her group sometimes refer to them for that.
Absolutely.
So I have seen that really help people reduce the stress of that on their life, because basically she just helps you come up with strategies to do things in a way that doesn't cause you as much stress as they are. So I always joke and say I need a session with her too. So I would highly recommend that.
Yeah, I'll just then add something there. The cognitive therapy is extremely important. Okay, I can't emphasize that enough. And Bonnie Shoddy, our speech language pathologist, is excellent with it. It is not likely, though, to change people's scores on neuropsych testing. Okay, I want to be clear about that. And that's not to minimize the importance, because what Bonnie does, and this is something we all can use, regardless of MS status, is that she teaches people to think more efficiently. You know, the old saying of work smarter, not harder, that's what the cognitive therapy does, okay? And I think it's absolutely essential for folks, particularly here, but also for if you're still working. When people are still working, Bonnie is superb at going into folks' workplace, looking at their jobs and how they function in their work environment, and then helping them create new strategies for managing the environment as well as themselves. And it's just really important because the two things that are most responsible for folks going out of work are fatigue and cognitive issues. Okay? So if you can at least address one of those through the strategies that Bonnie teaches, you've got a long ways to go. You've accomplished a lot, rather.
Okay, this is for Dr. Gotzel. You started on a path when you were talking about adrenaline, and then I think you changed gears, and I've had the feeling you didn't finish your thought, or maybe I just didn't follow. I'm not sure which, but anyway, so what piqued my interest was I think I tend towards social isolation, and specifically for a fear of behavior, that my behavior might be not socially acceptable, or because of overstimulation. Like if I was thinking in particular of church that I used to attend. It had a lot of gospel music, and I think I got myself just so worked up. I just kind of, it's safer to stay at home and not be overstimulated.
Okay, and I think that's a big concern for a lot of people, is how their behavior, how acceptable is their behavior going to be, and fear that they're going to do something that is not. One of the keys here is that you remove yourself from the stimulation. Part of the therapy is beginning to recognize, and Tracy talked about this, the awareness, and becoming more aware of your body and what happens when you start to become overstimulated. And at that point, you take yourself out of the overstimulating environment. Give your body, your emotions, all of that a break. Then you can go back in, okay? But generally speaking, if you can increase your awareness earlier in the cycle, you will avoid the behavior that comes from the overstimulation. It's just simply breaking that progression. Does that answer your question? Okay. Right. And one of the things we focus on is teaching folks to recognize the changes that go on in their bodies. Okay. So, that's part of the therapy.
Is it safe to say that upon being diagnosed with MS, that a person should have like a baseline testing of their cognitive issues so that can be monitored throughout the course of their treatment with MS?
In a perfect world, yes. The physicians at the MS Institute are doing a lot of that now. They used to wait until patients had complaints about their cognition, but they now are sending people for testing to the point we're having trouble at times keeping up with it. But yes, I think that's an excellent idea because then it can be tracked.
Mine is more so of a comment. I'm familiar with all three of you. Tracy Walker, she was my nurse practitioner, you, Dr. Godsall, and Mitzi Williams. I thought that you guys didn't tell me enough, but that's not true. I actually have more choices than I even realized. My website is the number 1, the number 2, the letter B, and the word happiest. One to be happiest at gmail.com. I had to realize a lot of it depends on me and my thinking and outlook on this whole situation. We don't have the answer, but many times the way we look at it and approach it, I'm finding it has more to do with this entire illness. And I've had it, well, I've known about it since '92. And it's good to know that too. We have more control over it than we think.
I'd like to make a quick comment. I've had it for this Thanksgiving is 20 years, and actually I had seen the Shepherd Center in 2003, and then I went into a long-term denial. In the past, I've went into secondary progressive, and the past 5 years has been hitting me hard. First, let me get something out of the way. This is my third MS News and Views seminar, and I don't know if it's a smaller group or the quality of the audience, but this is by far the best one. I think congratulations and thank you to all 3 of you speakers. I think you're great. And I'm hoping I can get copies of the slides because I'm not as fast as I used to be. What you've done here is great, and the rest of the audience, please spread the word, and I'm going to try and help Stu and you guys as much as possible. One of the biggest things that's helped me, and I'm fighting, is this being alone and this isolation and everything, and I appreciate the balance and moderation. So thank you. I wanted to make a comment about the neuropsych test that I should have done with the Shepherd Center a long time ago, and I didn't, but I'm a veteran, so I'm being treated in the Miami VA hospital, and a year ago I had a neuropsych test, and I kind of fought it for about a half a year to a year, and my interest is because my background is control engineering, and I love the controls point, emphasis on this, is the lesions and black holes in my brains and the functional mind mapping of what it's affecting and how it affects you. And surprisingly, the neuropsych test in their evaluation, I did very good on the test, but where I had my cognitive deficits actually corresponded to where I have the black holes and lesions. So even though I was very resistant towards it, when I opened up my mind and take a look real good at it, I was like shocked at, hey, wow, that's hitting the nail right on the head. And so I would encourage everyone here, don't be afraid of it, get it done. And had I done it back in 2003, then it would be a good baseline as to show over 20 years where I am today, which is obviously not that great. Because, Superman has kryptonite in his blood right now. So those comments out of the way, I want to ask all 3 of you individually to respond to this question. Aside from the greatness of everything you've done here, is what in the most recent research development in the MS, not only in the possible causes or medications or subsequent training and treatment gets you excited? And I'd like to, if you could please, each of you tell us what you think is great.
Let's start with Mitzi.
Well, it is absolutely an exciting time in the treatment of MS. I mean, Tracy and Dr. Godsell know, even, less than 10 years ago, we really didn't have very many choices, and now we almost have at least one new drug a year, and lots of other advances. So this is an amazing, very fast-paced, one of the fastest-paced growing fields in neurology for sure, but I think in medicine, period. I think the 2 things really get me, well, I'll just say one because I don't want to steal anybody else's. One thing that gets me excited, but also a little bit disappointed, is the research that's being done in myelin repair. So there is a lot of work trying to figure out how to fix what's already broken. You know, whenever I talk about disease-modifying therapy with my patients or in talks, I say, well, we can't fix what's already broken, but we try to prevent new things from being broken. And so there's a lot of effort moving toward trying to fix what's already broken. There was one drug that was being looked at, Anti-Lingo-1, which unfortunately failed its clinical trial in trying to decrease relapses, and it was targeted at myelin repair. They are still doing some research looking to see if it may be an additional therapy or maybe there are other measures they can look at. And I went to ECTRIMS, our big European conference, a couple of weeks ago, and we also had another myelin repair agent that unfortunately failed its clinical trial in Europe. So I am hopeful because there are several other agents that are still being looked at that we will find ways to regenerate myelin and fix it. So I'm hopeful and excited, but also a little disappointed at the same time, but hopeful that some of our other agents will make the mark and will be able to do more than just slow progression, maybe reverse some of it.
Kind of taking off on what Dr. Williams said, even though certainly I don't have the interest or the expertise that she does, but the whole notion of myelin repair. And the reason why I say that is because the most common complaint that people have about their cognition when they come in for testing is, I don't think as quickly as I used to. And they have that experience because of the effect of the, or the focus of the MS on white matter, which is where the myelin is. And when that myelin gets disrupted, that's where the nerve impulses get disrupted, and that's why people, their thinking slows down. It's a cognitive inefficiency. And so to hear about the possibility of myelin repair speaks, I think, to a lot of what happens for folks cognitively. The second thing I'm excited about, and somebody just gave me a paper on this week, was research that's going on about fatigue. For many, many years, fatigue has been very elusive in terms of being able to say, okay, what is this? You know, and the people's experience of fatigue is so varied. It's so variable. That's part of why we can't get a handle on it. And it gets confused with many other things, including depression. So those are the two areas that I'm most excited about.
I would say, and partially because I have to say this, but not really. So I'm really excited about some of the rehab research that's going on at Shepherd and across the country. My boss, Dr. Backus, just got a big multi-center grant looking at telemedicine and rehab over, with that technology, and I think that's exciting because we know we can really make a difference in fatigue and all kinds of things with rehab and exercise, and being able to reach people way out there that can't get to us is exciting. So, and then it excites me that we're looking at all the areas that affect MS, not just, MRI, not just medication, not just basic science, but we're looking at everything from that high science research down to practical day-to-day rehab research that can hopefully affect people where they're at, no matter where that is. So.
Next question.
I was attending a recent MS support group meeting, and within the past year I've heard from two different ladies that said that they had been given the word dormant for their MS, one being diagnosed over 30 years ago, the other one, approaching 65 and had been given this word dormant. So apparently that was just something I hadn't read anything about. And it just kind of gave me hope, thinking, yay, I can reach a word dormant one day, and I'm not going to have to fiddle too much with this, hopefully, because they're both looking at, leaving medications because it's apparently appropriate for them. And I just wasn't sure if you had run into that before.
Dormant is a hard one. So when you think about MS has different, I won't say phases, but kind of phases. So typically we think relapsing, remitting, we think secondary progressive. To me, remission, or maybe that's the word they were thinking of when they mean dormant, it may be a period of quiet disease activity, meaning no changes on MRI, maybe clinical stability. The difficulty with MS is that it's very unpredictable, and that can change. You know, people can be quiet in terms of not having things going on for 10 years and then have a new symptom. I do think that one of the main concerns for many of us as MS specialists is, at what point would we consider taking people off of medication or changing therapy? And I think the real honest answer is we don't know, right? So if somebody's quiet for 30 years, is it because their medication is working? And what happens when we take them off of that? And I think that we just don't know. I think that certainly when you sit down with your doctor, you decide what's the best decision for me. You know, how has my MS been doing? And I have had some folks that we've taken off of therapy after a long period of time of being stable, and some of them have done well and some of them have not. You know, the issue is just I don't have a crystal ball. I tell people my crystal ball is in the shop, and when I get it out, I'll let you know, right? So the difficulty is we just don't have that crystal ball, and there have not been a lot of formal studies that direct us as to what to do. But I think that people can have periods where their disease is quiet. I think dormant may be a good word, because dormant kind of gives the implication that it can be reactivated. But the answer is we don't really know how long it will stay that way, and if we stop what they're doing, will that make them no longer dormant, I guess.
Anybody else have a comment up there about this? On there. You guys? No? Okay, next question.
Going back to the term dormant, we heard a term at a program we did night before last called NEDA, no evidence of disease activity. Can you expand on that?
Yes, so NEDA is a composite measure that's being looked at in research studies. It basically means you have no progression on MRI, you have no progression of disability, and no relapses for a specified period of time. Usually in a research study, it's about 1 to 2 years. So it is a measure that's being looked at to basically see if a drug can, so to speak, stop the disease in its tracks. The difficulty, again, is the long term, right? So certainly we know that MS by itself can be quiet, or, you know, you can have nothing going on for, 2 years or 3 years or 4 years, evidenced by people who will have, for instance, optic neuritis, and then it'll resolve. They'll not go see the doctor, and then nothing else will happen until 5 years later, right? So MS can do that on its own. The medications help that. I think the good thing about NEDA is that we're now raising the bar in terms of our expectation of medications, right? So now we're looking to see if we can stop all components of disease activity, and also looking in some studies to see if there's improvement in disability. So we're raising the bar, but I think that our therapies are not quite there yet in terms of achieving that long term.
So going further, though, with this discussion about the meds halting disease progression, or people showing no further disability, now, though, the big issue, the insurance companies.
Absolutely.
And what they're doing to many of us, and now I'm part of this, many of us, all right, that the people that prescribe and give me what I've been doing so well with no longer want to give it because I've been stable for so many years. So where does the battle go from here?
So I think that certainly patients have to be advocates. We as healthcare providers have to be advocates. It's always a difficult thing because the doctors, we're working. You know what I mean? Like, we're taking care of people. So, we don't necessarily, go sit and lobby on Capitol Hill for, weeks and months at a time. But I think that certainly we as a community have to band together and demand that the insurance companies give access to these medications, because you're not the only one that has happened to. Several of my patients have experienced it, where now insurance companies are dictating, basically practicing medicine without a license.
Right. Tracy, you started to mention something about this. Can you go on with that?
So I think this is becoming a really almost a crisis in our country. And I know that as a provider, we feel like control of our art, our job of healing is being robbed. And I think you guys, and as well as us, need to be vocal, we need to be active, and we need to say, we're not going to stand for this. I really feel like the battle has formed on the insurance front now. And I would not assume or stop if, fighting things. If you're being told you can't have a medicine, you can't do a treatment, you need to take it to the highest level you can. And know that there is an office in the state of Georgia and other states that you can actually file complaints if your insurance is not giving you proper care or access to care. And I would encourage everybody to use those routes to make yourself heard and your situation heard, because I think it's only going to get worse until we all scream and fight.
Hi, yes. Thank you all so much. It was very informative. I have a question for Dr. Mitzi and also Dr. Gonzalez. As far as continuity of care, you talked about the care team. I know it's important for, when you see the neurologist, that this information is fed to the PCP consistently, correct? That every visit that information should go to the PCP. But what about that feedback from the PCP to the neurologist, because so many other things could be going on medically? What are your thoughts on that feedback loop for continuity of care purposes?
So I think it's important. I do think it's important that there be multiple lines of communication open. I think certainly oftentimes it's not an automatic system. So again, when we talk about being your own advocate, many times if someone reminds me, oftentimes we'll have a standing order to send notes to the PCP, but if someone reminds, or when you go see your doctor, oftentimes people will say, hey, Dr. Williams, can you just send your note to my PCP, or your PCP, you send your note to my neurologist. Oftentimes that helps facilitate, because if I see you once a year or twice a year, and your PCP sees you once or twice a year, there usually isn't a button where we just say, okay, this note will automatically go through cyberspace, somehow reach your PCP. So if you just give your doctors quick reminders, that's helpful.
Okay, thank you. And Dr. Goodsall, you talked about challenging your thinking. Are you specifically referring to just really focusing on what you have control over versus not? Is that what you're referencing?
Yes.
Okay.
I'm sorry. Yeah, that's exactly it. I was thinking about this. I'll do this very quickly. That I mentioned that the most common complaint people have when they come in for their testing is, I don't think as quickly as I used to. The subsequent statement is, I must be getting stupid. I'm getting dumber. And it's not the case. But this is an example of how people's thinking can spring out of this experience that they're having. And when I do test feedback, I pull out the tests where I can make a comparison of the pure ability under untimed conditions versus the same ability being used under timed conditions. And invariably, there is a difference. And we emphasize then that your pure ability is there. It's not gone anywhere. Now, you do get penalized under time conditions, but that can be addressed. You go to Bonnie Shoddy and she teaches you strategies for, like I said, working smarter, not harder. Does that get to your question?
Is that where you just really focus on what you have control over versus not?
Absolutely.
Okay, that's what. Thank you.
Yes, I had a question earlier. I think Dr. Mitzi was talking about optical neuritis, and some medications around that. And can you further let me know what those are?
Well, I'm not sure specifically. I did speak about optic neuritis. When we talk about symptom management, there are some symptoms that we do have specific treatments for. If someone comes in, or if you have symptoms of a relapse, for example, like an optic neuritis, relapse symptoms can be treated with steroids. Corticosteroids are the most common treatment we use for relapses. But then in terms of symptom management, there are specific symptoms that do have treatments. Optic neuritis itself does not have a specific treatment, but for instance, if people have numbness or tingling, there are medications that help that. If people have spasticity, there are medications that treat that. But general symptoms are treated with steroids, but some have specific. Optic neuritis just doesn't have a specific treatment. It would be corticosteroids.
Okay, this one is a bit difficult possibly, but I need all three of you all to think about this and give any comments about this. All of us MSers in Georgia, Alabama, nationwide, even in Europe or what have you, we all desire to have a cure. In my studies, knowing that a cure is just really something putting a Band-Aid on the MS, but we want it to be healed. I know through FDA there are many therapies that have been approved, and there's been research that has been done since I know of when I was diagnosed in '92, and even before I was diagnosed. Realistically speaking, and all three of you can answer this in whatever manner you may answer, but do you really feel that there is going to be a healing for MS with the many different therapies that are out there, that we MS patients can be off of any and everything, knowing that we have the different symptoms, different diagnoses, and things of that nature? Do you realistically believe that there will be a point in time where we can be healed of MS altogether?
Who's first?
That's a tough one. So I will answer it in two parts. So do I think that there are the potential for interventions that may prevent people from having to be on therapy long term? I do, right? I think probably the closest thing that we have to a cure would probably be stem cell therapy, which we still have a very long way to go in terms of stem cell therapy. The research has been done for the past 20 or 30 years, right? So it's not new, even though it's a hot topic. But I still think there are lots of kinks and things that need to be ironed out. I think that in terms of an intervention, once someone is diagnosed, that may kind of stabilize things and keep them from having to be on further therapy. Stem cell will eventually be that avenue in whatever form it eventually takes once it's approved. I do think, however, there still will be difficulty with figuring out how to fix what's already been done, right? Because there are a couple of issues with MS. When you do a very aggressive intervention like stem cell therapy, oftentimes it's after people have had a lot of damage done. And so the issue would be when to do an intervention like that, but I think still the other issue would be that still does not fix what's already been done. So I think there will have to be kind of two parts to it to try to fix what's already been done. Because if you think about it, by the time people come to diagnosis, they often already have lesions, right? So we're not going to go around with a portable MRI and just MRI everybody from the time they're 10, to see, oh, you've got a spot, you're going to get MS, we better do something. So I think that there still will be that issue. I think that it will come in two parts. The inflammatory part of MS we're very good at treating, but that degenerative part, we still have a ways to go on how to fix that. So do I think there may be a point where people don't have to be on medications long term? Yes, I think that we have a way to go before we can say that people would be completely healed in terms of fixing what's already been done.
Anybody else have an answer for that? Okay, good.
Nobody wants to touch it.
So before we get to the next question, we only have time for another 5, maybe 6 questions, and then that's it for the day, all right? So just letting you all know. And by the way, thank you everybody so far for all these great answers.
Okay, my question goes back to the question about the dormant MS. What's the difference between dormant MS and benign MS?
So many people believe, when I went to ECTRIMS, many people believe there's no such thing as benign MS. So benign MS is this term that we were using for folks who have relapses and then they go completely back to normal, relapse, go completely back to normal. I think that what we find over time is that eventually most people will have some progression in some form, even if it's very mild. So that's not really a term that people use very much anymore. From what I don't know, Tracy, if you hear it very much anymore. Yeah, we don't really use that very much anymore. But I think the difference between benign and what someone was describing as dormant is benign would be, again, relapse, go back to normal, relapse, go back to normal. Dormant would be maybe you've had 5 relapses and you have a certain level of disability and you just don't change for 10 years. If that makes sense.
Anybody else? Nope.
Okay, I wanted to mention 2 points when it comes to issues that you think I'm pretty sure that you need to address as MS patients. Get the phone number and the address for your state rep and your congressperson and call them and let them know what your needs are and how you expect them to vote for you. And I'm a grandmother of a 9-year-old grandson and a 12-year-old grandson, 9-year-old granddaughter. And when I forget things, my granddaughter say, "Nana, what's wrong? Is it you, an old lady, Nana? Why we already told you that?" I said, "Yeah, I'm an old lady, Nana. Yeah, that's why."
Great.
But that was the only thing I wanted to express as far as when you're frustrated with what we can and can't do as patients, that when you're a registered voter, I feel like they're supposed to be representing you, so they should hear from you. And even possibly in the past, when my children were minors and they're adults now, I went to my congressperson's office in reference to my special needs son. So I like to know who
Be your
I'm
own
voting
advocate.
for.
Absolutely.
Thank you for your comment. Yes.
Good afternoon. My question is, I hear often, we know the progressiveness of MS, but I've had many MRIs, and over the last 10 years specifically, with the disease-modifying therapies, I've had many different kinds with positive results. In other words, the doctors will say, we seem to be keeping it at bay, but yet I feel the disability continuing on, whether it be weakness in legs, MS hug, and worse, etc. I realize it's a progressive disease, but just want to pose that question to you and see what some of your responses are.
Well, I think one thing that a lot of times we don't take into consideration is just the cycle that occurs as we become less able to do something, then we do it less, then we're even less able to do it. So there's that deconditioning piece that I think we don't give its due in MS, because nerve fibers, they need practice and education, and they need to be used to remember how to do what they need to do. So it's just, I think, also important to just stay as active as possible to try to slow things down. I think, we can see on MRI plaques and changes that may at one point not cause you a problem, but later on start to cause you a problem because you're aging and you don't have that neuroplasticity to work around it anymore. So sometimes, as providers, when we say, "Oh, your MRI looks good," it doesn't necessarily mean that there's not going to be something going on clinically. So.
Right. Absolutely. And just to add to that, there is often this mismatch between the MRI and the condition, right? And so I tell people when we look at MRIs, it's kind of like looking in a mirror, right? So you look in a mirror, it has a certain level of detail. If you look in a mirror like in the bathroom here at the hotel, right? If you go to a hotel that has a mirror that has 10 times the magnification, you can see every pore in your face. And so there are limitations to what we can see with the imaging we have. And so when we look at an MRI and we see a white spot, we know that damage has occurred at some point in that area, but it doesn't tell us what percentage of the nerves are working. So maybe when you first diagnosed with MS, maybe 90% of those nerves are working. And then maybe 10 years in, as the neurodegeneration and the nerves start to die away, maybe when those nerves start working, maybe when 60% of them are working, that's when you start to notice things getting worse. And we just don't have the imaging techniques to be able to see that level of detail yet. And so there can be changes going on in the spots that you already have that are causing you to lose function. But when we look at your MRI, we just can only see that the spot was there. We can't see that detail of what percentage of the nerves are still working there.
Dr. Godsell, I have a question for you, and that is that for many MS patients that are showing depression or whatnot, and that you know that they're living with family, do you suggest that they bring in the family as well to, try to work on the actual emotional impact on the family as well?
Yes, if the family's willing to come in. My biggest concern that happens in families is the frequent misunderstanding of what is happening with their family member, and that depression and or anxiety can produce a great deal of variability in behavior, particularly when you throw in fatigue, because you have people then who are very active and looks like my wife or my husband as I've always known him or her, and then 2 days later there's a complete collapse and the person becomes fatigued, and the depression also plays into that, and the family members kind of like, what happened? And there is a tendency to attribute psychiatric reasons, and so most often when I have family come in, we speak to that, we address that. It's largely a psychoeducational model that we begin to address.
Thank you. Thank you.
Yes, I just had a question/comment. As a retired occupational therapist, I'm a huge advocate of functional outcomes, and Shepherd is really a place I see that's doing that right, and it seems to be set up to be I look at the different types of challenges that Shepherd addresses, and it seems like that's the biggest weakness in, as you use the term, MSers that we face, and also other persons like with it may have TBIs or things like that, is the fact that it's not well defined, but it is the impact on our lives is very felt, very well defined. And I just was wondering, is there any collaborative research being done? I think about like the triggers for depression and anxiety both can be very similar, and that's one part of my question is like, is there any collaborative research being done across the different diagnoses that Shepherd serves? And the second statement I just wanted to make was that I think it is important for us to speak out about how to not allow insurance companies or other individuals to minimize the importance of those functional outcomes in our function, because it's not time yet to take the care out of healthcare, and I think that's what Shepherd does right, and I think that's why there's the success that there is.
Thank you.
Well, I'll thank you. I'll speak to the outcomes piece because that's one of the things I've been doing for the last couple of years is working on what are the benchmarks in MS? And when I say benchmarks, a lot of disease states, take hypertension or diabetes, they know what number they're shooting for, what outcomes that they need to be meeting in terms of giving patients good care. And with MS, we're a little bit behind in that, and I think it's hard because MS can be so different across the board. So I do think we as MS providers need to come up with a way to measure what we're doing and make sure that it's what you need us to do. So I think there's lots of collaborative research and things that are being done to work towards that. So that's great. I'll let Dr. Godsall answer the other.
Well, I wasn't sure what the question was about the other part.
Essentially, I was just thinking of the similarities in I went a little tangential, but what the point I was trying to get across was the similarity between kind of the invisible disability of like MS and something like traumatic brain injury that is also serviced by Shepherd Center. And if you found any similarities in those two, I just feel like that there can be kind of a sense of invalidation when people don't see the direct disability, and I think that walking wounded effect occurs across both diagnoses, and I wondered.
Absolutely. I mean, people talk all the time about, that MS is a hidden disability. It's not obvious for many years in people, and there is, a tendency on the part of families, as I spoke to a minute ago, but also in community, kind of dismissing, the person because the disability can't be seen. And it's a very difficult process. There's a support group out in Gwinnett County. I don't know if they still do it, but they used to have a T-shirt that said, "I'm not drunk, I have MS." And, it speaks to that sense of invisibility, and so, this is something that I think needs to be worked on through education, predominantly, but to kind of get that information out there.
Next question on set.
Quick question. I just want to know, what are your particular views of cannabis with MS?
I will go there just a little bit. I think that they're just like when you talk about stem cells, there's a lot of different forms and formulations and parts of that compound that you really need to be educated about what does what. And I think personally, I think there's some exciting potential when used correctly, and may be something that helps conditions and people like with chronic pain, and then maybe I don't know, Mitzi can probably talk more about the effects on the immune system, but I think we need more research, and unfortunately I think there is a political, cultural, issue with that speed bump, if you will, that we need to get across, because I think there may be potential there.
I would agree. I mean, so most of the clinical research that we've seen so far has been with more of the oil forms. The research that's been promising to show effects on symptoms has been with the oil form of cannabinoid oils. I think that certainly there are some symptoms that it could help, including chronic pain and spasticity. Those are the things that most likely have been affected. I do, however, at this point think that a lot of people do self-treat anxiety treat it with anxiety. So I think that, again, many things with MS wind up being kind of a vicious cycle, right? You have symptoms, those symptoms cause you stress, you know what I mean? The stress makes the symptoms worse. And so many people do self-medicate, I think, some of their psychiatric symptoms with marijuana. And so I think that, you know, as a medical community, you know, we have to find that balance, right? Because you know, there are effects. You know, I have some folks who use it illegally, which is, you know, which I have to say, I don't prescribe, but I do have some folks that use it in small amounts and it does help symptoms. And then I have some folks that use it and then they're like, oh my God, I wake up every day like, where can I get something to smoke? You know what I mean? So I think that, you know, the difficulty is that we have to find the form that is the safest, you know, for people to use, that is effective, and make sure that we have good research behind what we're doing. But I do agree with Tracy that there is some promise there.
Hi, Dr. Williams. I have a question for you.
Okay.
I know you don't
I've got
have
an answer.
I know you don't have the crystal ball, but based on your knowledge and your experience, do you ever find a line where you would say this person is too far gone for any help if there is ever a cure?
I don't know. I mean, it would depend on what the cure entails, right? You know, so again, you know, there are some people who have very advanced disease, you know, who have a lot of disability. Many of our newer therapies can be very harsh on the body, right? I mean, so we're talking things that wipe out your immune system to a certain extent. If we're talking about things like, for instance, stem cell, that's a pretty significant stressor on the body, right? So if someone is already very, very debilitated from their MS, we do have to weigh, okay, would you be able to tolerate this and would it be able to help you? I do not think that anyone is so far gone that there's not anything that we can do in terms of, you know, even if folks aren't on disease-modifying therapy, there's other type of physical therapy, other things we can do to make them, you know, comfortable or what have you. But I think that certainly, you know, it would depend on what the cure entailed.
We just have 2 questions remaining, one from Jeff over there, one from myself, and then we have to end this, okay?
And this is kind of a biased question because of the talk I just gave, but I personally have never seen somebody get an exacerbation from overexercising, and I've heard lots of doctors speak about that as well, that they're not inducing an exacerbation from overexercising. More often, it's underexercising that may cause an exacerbation, or not at all, or just being sick and unable to do stuff. But the question is, within it's a social issue as well, because the self-esteem is increased when people exercise, and there's also a better sense of accomplishment, and they get results and so forth and so on. How can we get the point across to patients that it is good, and you know, you got to try it before you I mean, can you guys as physicians can write a script to play or to, you know, to exercise? It doesn't have to be physical therapy. Physical therapy is great, but not everybody needs that. There's just I mean, I don't know what your stance is on, do you see people getting exacerbations and getting worse because of their exercise, or the opposite?
No, so I don't generally see folks have exacerbations from exercise, and I think, you know, as providers, we encourage people. I encourage everybody to exercise. You know, they just have to find the thing that they like to do. For some people, it's hiking. For some people, it's swimming. Some people, it's dance classes, or, you know, whatever the level of ability is. But there's always something everybody can do. So I generally try to encourage people to be active, and, you know, now exercise can temporarily make some symptoms recur if they get overheated, right? So I have a marathon runner, one of my patients who has optic neuritis or had it, and when she gets into about 4 or 5 miles, like her vision goes out a little bit, and then she'll rest and then start running again. So I do warn people about that, but I've not seen people have exacerbations from exercise. I just encourage them to keep moving.
Did she answer you? Great. Can't keep going. I'm sorry. I would love to keep going. All right. So firstly, I want to thank you 3 for coming here today.
Thank you.
It was awesome. It was great. It was very good. Thank you very much. And from those that remain in the room, did you learn something today? I guaranteed it, so I'm glad you said yes. Thank you very much. Again, we want to thank Sanofi-Genzyme for, providing us the grant to do today's program. And I want to thank all of you, because we can't do our programs unless you're here to be there for them. And of course, I want to thank this board here, this panel. This was great. I would love to do it again. So let's all say yes, and we'll do it again. All right? Great. Thank you, everybody, for coming.